So today I'll be discussing the surgical anatomy of aortic valve and aortic root. So the aortic root is basically the anatomic segment between the left ventricle and the ascending aorta. It contains the aortic valve and other anatomical components which function as a unit and support the leaflets of the aortic valve. It is bounded distally by sinotubular junction and proximally by the base of the leaflets of the aortic valve. As you can see here, the sinotubular junction marks the distal boundary of the aortic root and the level of the basal attachment of the cusps marks the proximal boundary. So the components of aortic root are sinotubular junction, aortic sinuses, aortic cusps, aortic annulus, subcommissural triangles which are also known as interleaflet triangles, and coronary ostia. I hope you can see clearly all the distinct components of the aortic root. Here is the sinotubular junction, which looks like a ridge at the distal aspect of the aortic root. We have the aortic cusp or the leaflets, we have the coronary ostia here, and these are the subcommissural or interleaflet triangles. So we'll be dealing with each component in detail now. The sinotubular junction is basically a small ridge of transverse collagen and elastic bundles which is present at the distal extent of the aortic root. It marks the transition between the aortic root and the ascending aorta. It is not completely a circle, but it basically takes the contour of the three sinuses, giving it a scalloped appearance. The dilatation of aortic root in this area will give rise to aortic regurgitation or aortic insufficiency. Now moving on to the aortic sinuses, these are basically the outpouchings or dilated pockets of the aortic root which form the outer component of the aortic valve leaflets. So corresponding to the three leaflets of the aortic valve, there are three sinuses, and the nomenclature of the sinuses is based on the origin of the coronary arteries from the respective sinus. So for the right coronary artery, it is called the right coronary cusp. For the left coronary artery, it is called the left coronary cusp. And the third sinus, which does not give rise to any coronary artery, is then called as the non-coronary sinus and sometimes also referred to as the posterior aortic sinus. Now, what is the function of these aortic sinuses? So during the systole, the leaflets, they move towards the sinuses. The function of these sinuses is to allow the leaflets to take space without actually occluding the coronary artery orifice and therefore guaranteeing the myocardial perfusion during the entire cardiac cycle. Now when the systole peaks, that is at the beginning of the diastole, the blood flow enters at the level of the ridge on the sinotubular junction and then moves along the wall. This generates eddies and currents between the cusps and the arterial wall, and this facilitates the closure of the aortic valve in diastole. So the aortic sinuses, they function throughout the cardiac cycle to maintain the proper opening and closing of the aortic valve leaflets, as well as to maintain the myocardial perfusion through the coronary arteries during the entire cardiac cycle. So the aortic valve is normally tricuspid and is composed of three delicate cusps and sinuses of Valsalva. All the three cusps are semilunar in shape and they are composed of three components: the hinge, which corresponds to the attachment of each cusp to the aortic valve, the belly, and the coapting surfaces. So as you can see here, each cusp has a belly, a hinge, and a free edge. The free edge of each cusp is tougher consistency than the remainder of the cusps, and at the midpoint of each free edge is a fibrous nodulus, which is also known as nodulus of Aranti. On either side of each nodulus is the lunula, which forms the area of coaptation during the valve closure. The commissures of the aortic valve are the points where the three cusps or leaflets of the valve, they attach to the aortic valve. As you can see here, three cusps, correspondingly three commissures. A normal aortic valve has three commissures and it provides support and structural integrity to the cusps and helping them to open and close properly. So as you can see, the hinge part of each cusp attaches to the aortic valve in a semilunar fashion. So this leads to the formation of a coronet-like shape or a crown-like structure. Instead of a ring instead of a completely circular ring, the aortic annulus is described as a semilunar or coronet shaped crown like structure which is delineated by the hinges of the leaflets. It provides structural support to the aortic valve as it joins the aortic media distally and the ventricular septum proximally and anteriorly. So you can see there are different parts of the aortic root and the annulus. The green ring, it signifies the sinotubular junction. The yellow portion is again the coronet or the crown like structure which corresponds to the semilunar attachment of all the three cusps to the aortic wall. The blue ring shows the ventricular arterial junction, and the red one is the basal ring, which is actually a virtual structure formed by joining together of the proximal attachments of the valvular hinges. Now we'll be talking about the interleaflet triangles. So there are three cusps, and in between all the three cusps we have three interleaflet triangles. These are actually the subaortic segments. These are the junction between the aortic root and the ventricular outflow tract and is composed of three triangular shaped areas. The triangle between the right and the non-coronary sinuses partially includes the membranous septum, as you can see here. The triangle between the non-coronary sinus and the left coronary sinuses is the part of aortomitral curtain. The triangle between the right and the left coronary sinuses in continuity with the ventricular septum is muscular at its base and fibrous at its summit. Now what is important to know here is that the bundle of his is normally located at the junction between the membranous and the ventricular septum in the subcomistral area between the right coronary cusp and the non-coronary cusp. So this area is specifically of very great importance during the aortic valve procedures, as injury to this area can lead to conduction abnormalities. Now relation with the mitral valve, as we saw that the portion of non-coronary leaflet, that is non-coronary cusp, it continues with the anterior mitral leaflet, and that portion is called aortomitral curtain, which is a fibrous continuity between non-coronary cusp and the anterior mitral leaflet. On the either side of this aortomitral curtain, the thick fibrous structures are the right fibrous trigone and the left fibrous trigone, which form as a part of the fibrous skeleton of the heart. And as we saw that this interleaflet triangle between the right coronary leaflet and the non-coronary leaflet has membranous septum beneath it. Now this right fibrous trigone and the membranous septum, they are collectively known as central fibrous body, which again is a part of the fibrous skeleton of heart. Now coronary ostia, as we saw that the nomenclature of the aortic sinuses corresponds to the coronary artery arising from that sinus. So there are different nomenclatures proposed. The one that we will be seeing here is, if we place ourselves in the non-coronary sinus, then our right hand would signify the right coronary sinus, and it is called as coronary sinus number 1, and the left hand will be corresponding to the left coronary sinus, which is usually named as number 2. Now looking at the overall relationship of the aortic root. So we have a very beautiful article by Anup Sood, and this is a diagram from that article which gives us a complete comprehensive relationship of the aortic root. So here we have different colors, blue, orange and green. The orange one is the right coronary cusp and right coronary sinus. So the entire right coronary sinus, it lies adjacent to the right ventricular outflow tract. The central part lies adjacent to the crista supraventricularis. The left part is adjacent to the area of RVOT in the angle between the crista supraventricularis and the pulmonary valve. The posterior or the non-coronary part of the right coronary sinus is related to the area of the right ventricle, which is postero-inferior to the crista supraventricularis. Now inferiorly, the entire right coronary sinus is related to interventricular septum. The muscular septum lies under the central and left parts, while either membranous or muscular septum may lie under the posterior part of the right coronary sinus. Now this blue portion signifies the non-coronary sinus or non-coronary cusp. So the atrial chambers with the intervening atrial septum, they lie adjacent to the non-coronary sinus. The right and central parts of the non-coronary sinus are related to the right atrium and the interatrial septum. The left part is related to the left atrium. Inferiorly, the right part, like the posterior part of the right coronary sinus, may be related either to the membranous or the muscular part of the interventricular septum. However, beneath the central part of the non-coronary sinus, the membranous septum is fairly a constant structure. The left part of the non-coronary sinus inserts into the anterior mitral leaflet. Now, this green portion signifies the left coronary sinus or left coronary cusp. Relations would be posterior part of the left coronary sinus shares the same relationship as the left part of the non-coronary sinus. That is, it is related to the left atrium posteriorly and to the anterior mitral leaflet inferiorly. Now, the central part of the left coronary sinus is the only part of the aortic root that is not related to a cardiac chamber. It is adjacent to the epicardium only. The right part of the left coronary sinus lies adjacent to the pulmonary trunk at the level of left pulmonary sinus. Inferior to it lies the muscular ventricular interventricular septum. Now, looking at the histology part, so each aortic leaflet has three components. Fibrosa is the outflow surface of each cusp, which is composed of bundles and sheets of collagen. Then we have the another surface, ventricularis, which is the ventricular surface, and it is all again composed of collagen and elastin fibers. In between these two layers, we have spongiosa, which is mainly composed of glycosaminoglycans, and its function is basically energy dissipation and lubrication of movements between these two layers, that is fibrosa and ventricularis. Now, physiological movements. So, how does this aortic root functions as a dynamic structure during the cardiac cycle? During early systole, a downward movement, a downward displacement of the aortic annulus is caused by the isovolumetric contraction of the left ventricle, and this initiates the opening of the aortic valve. Now, during late systole, the aortic circumference decreases as a result of ventricular contraction, while the circumference of the sinotubular junction increases as a result of increased pressure. Now, during diastole, again the aortic valve closes and the annular circumference increases as a result of the aortic backflow. The sinuses of Valsalva, they dilate and the commissures move inward because of the elastic property of the aorta and the load on the leaflets. Now, we will be discussing the applied anatomy of all this that we have discussed so far. So, bicuspid aortic valves. Normally, the aortic valve is tricuspid. However, it can also be bicuspid. It is one of the most common congenital cardiovascular defect, and it is the cause of about 50% of adult aortic stenosis. What is the complication of having a bicuspid aortic valve? It can cause stenosis, it can cause regurgitation or both. It can lead to aortic dilatation in case of bicuspid aortopathy, and even dissection is possible. Aortic insufficiency. So, if a pathological process causes the shortening of the length of the free margin of a cusp, or if the sinotubular junction dilates, the cusps cannot coapt properly in the central position, and this results in aortic insufficiency or aortic regurgitation. If the length of a free margin is elongated, the cusp will prolapse, and depending on the degree of the prolapse, aortic insufficiency can again occur. Now, aortic root widening. So, sometimes in some of the patients with aortic stenosis, the aortic annulus is very narrow, and this would permit the implantation with only small sized prosthesis. Now, sometimes the size of the prosthesis from the standpoint of view of the size of the patient, that is with respect to the body surface area, it is not sufficient for the patient. So, in that situation, we have to cut across the aortic annulus. We have to widen the annulus with a patch and then implant an appropriate sized aortic prosthesis into that enlarged aortic root. This process is known as aortic root widening. So, the spots for aortic root widening, we have three places from where we can cut across the annulus and widen the aortic root. The first spot is at the LCC and NCC commissure. The other spot is into the annulus through the non-coronary cusp, and the third spot is to the left of the origin of the right coronary artery. Why we cannot place the incision at other places in the annulus? Because we can end up damaging the right coronary artery or damaging the AV node or right ventricular outflow tract, and the fourth reason is that all the other places are inaccessible due to main pulmonary artery. So we have two kinds of aortic root enlargement procedures. Either we can go anteriorly or we can go posteriorly. Anterior approach, we have Kono-Rastan and Ross-Kono. In posterior approach, we have Nix procedure, Manoogian procedure, Neues procedure, and Boyang procedure. So here we can see that in Nix procedure, we go through non-coronary cusp. In Neues procedure, we go between the commissure, between the NCC and LCC, but we do not end up going into the anterior mitral leaflet. Manoogian is actually an extension of Neues procedure, where we also cut across the anterior mitral leaflet and sometimes also LA. This gives us increasing the size of the annulus up to 2 sizes of the valve. Then we have Boyang, where we give an inverted bi-incision posteriorly and widen the aortic root. This again is the surgeon's view, which is showing how we give an incision in Manoogian and how we give the incision in Nix. So after giving the incision, we widen the aortic root by putting a patch. It can be a different shape of patch depending upon our approach and the type of surgery that we are doing. It can be a tongue shaped patch, it can be a pantaloon shaped patch. Sometimes we also might require 2 patches in some of the procedures of aortic root widening. After that, we place the aortic valve prosthesis into the enlarged annulus. Thank you.